Hello everyone, this video demonstrates laparoscopic TAPP plus for a case of large LIF incisional hernia. So this was a lady who had total abdominal hysterectomy, and through the left iliac fossa, through the left corner of the incision, a large incisional hernia. You can see the CT scan image where the gut contents were there, along with mainly the sigmoid colon was there. So after going inside, did the adhesiolysis, and we found that there's a loop of sigmoid colon which actually slided along with the hernial sac. So it's a kind of sliding incisional hernia which is similar to the sliding inguinal hernia. So in sliding inguinal hernia, sigmoid colon goes along with along as a part of the hernial sac. So in this case also, the hernial sac, the part of the hernial sac is formed by the sigmoid colon and mesocolon. So I just didn't try to dissect the sigmoid colon or reduce the sigmoid colon. Rather, I started raising the flap. So you can see at least 6 centimeter proximal, staying proximal to the proximal border of the defect. I started raising the peritoneal flap. Peritoneum was super thin, but I tried to start from laterally, where the peritoneum is a bit loose and the fat is there, preperitoneal fat is there. And here you can see the peritoneum is very thin. So my backup plan was, if there is any peritoneal tear, I would convert it to TARM with TAR. But very gently I proceeded, and you can see the gradually the peritoneum is coming, peritoneal flap is raising, and I believe once I would cross the arcuate line, the peritoneum will become loose. So I stayed very gently. I started dissecting. Medially also I came onto the medial border where the peritoneal fat was there. So here in this part, mainly the peritoneum is very thin. So here I very gently dissected, took some preperitoneal fat along with the flap, peritoneal flap, so that the flap becomes thick. Here also, in coming onto the medial aspect, I got some preperitoneal fat, as you can see. So I took the peritoneal fat, and that is the arcuate line. You can see once I you went beyond the arcuate line, there was no posterior rectus sheath, there was preperitoneal fat. So I it below the arcuate line, it becomes easier to raise the peritoneal flap. Again, going on to the before targeting the sac, I just created some space on the surrounding aspect of the hernial cavity, hernial defect rather, hernial defect. So you can see I'm staying close to the muscle, and reducing the peritoneal, raising the peritoneal flap along with the lateral abdominal flap, and medially also the preperitoneal fat. So idea is to create at least 7 centimeter flap, 7 centimeter peritoneal area all around the defect. Here the peritoneum hernial content was sigmoid colon. Small bowel got automatically reduced. So I just tried to dissect the margin of the defect, and I asked my assistant surgeon to put pressure from the outside, so that the sigmoid colon along with the hernial sac comes inside. So you can see I'm pulling the hernial sac very gently, and I can see the pseudo sac, the whitish layer is the pseudo sac. I just tried to reduce the pseudo sac and separate it from the hernial sac. So you can see the pseudo sac, it's similar like inguinal hernia that we do the dissection. So in inguinal hernia, also in direct hernia, mainly the pseudosac, you will find the pseudosac. So you try to reduce the pseudosac and take the preperitoneal fat inside. So here in the similar way, I just try to reduce the hernial sac, and that will automatically reduce the sliding hernial component, which is a large loop of sigmoid colon. So this lady underwent a classical cesarean section, and in the past, two classical cesarean section, and one transabdominal hysterectomy with a phalansteal scar. So this hernia is actually happened through the left lateral end of the TH scar, and over the time it has increased. The TH was done 3 years back, and this lady presented with on and off abdominal pain and chronic constipation, And the after proper evaluation she was taken up for surgery. So now you can see I'm just trying to reduce the hernial sac along with the preperitoneal fat, which actually slided down. So I just very cautiously avoided the holding the gut with my instrument. So gradually you can see it came out. And now you can see the defect margin clearly. So the proximal and the distal defect margin, all around the defect margin can be dissected clearly. And the automatically, with the reduction of the hernial sac, the sigmoid colon came inside. So here in this part, once I have identified the defect margin, I have decided to do the dissection close to the defect margin, so that everything can be reduced and I can go beyond the defect margin. So medially still there is some amount of sac left. Here you can see. So good amount of traction of the sac will actually help me identify the plane of dissection. Here you can see the plane of dissection is identified. Here you can see the medial margin of the defect is in very close relation with the inferior epigastric vessel. So I was very cautiously dissecting the inferior epigastric vessel and separating it from the hernial sac. And you can see the inferior epigastric vessel is actually coursing just close to the hernial defect on the medial aspect and going towards the pelvis. So there are small perforators which actually get branches from the inferior epigastric vessel. So better before dissection, better to coagulate it, because sometimes it can bleed. So and further dissection is proceeded beyond. So at one point of time, when we reach the groin area on the medial aspect, it is more like a groin hernia dissection. So and here you can see the inferior epigastric vessel, and now the round ligament will come up. So we have reached the left groin area, and laterally now I am trying to dissect the dulux fat. So here is the creating a plane between the preperitoneal fat and the dulux fat, so that I can go further laterally and create further space to place a large mesh with good overlap. So now you can see I'm just trying to separate the dulux fat from the periperitoneal fat, and further dissection is proceeded forward. Here is the round ligament. So round ligament can be divided and cautiously and properly coagulated. And once it is divided, further dissection beyond it can be done, similarly like inguinal hernia dissection. Now coming on to the medial aspect, so I need to dissect further more to get adequate space on the medial aspect. So we have to create the space of Regius. So there were history of multiple surgeries, lower abdominal surgeries in the past. So there will be some additions. The preperitoneal pain will not be very easy to dissect, but we need to have the proper understanding of the anatomical aspect, and the bladder can be adhered. So I'm just trying to divide the fascia transversalis and getting into the preperitoneal plane nicely, and safeguarding the inferior epigastric vessels. So here you can see I'm just trying to create further space. So medially the part of the urinary bladder will come. So bladder should go down along with the peritoneal flap, and so medially you can see there will be the urinary bladder will be coming during the process of dissection, and we need to identify which is the part of the urinary bladder, and inadvertent injury can happen in this kind of complex hernia cases. So we have to be cautious. So just trying to dissect. So now you can see there is medially the bladder has come, and I'm just trying to identify the correct plane of dissection. So here this is the bladder. A little bit of further dissection is required, so I've decided to go down further to expose the pubic bone, the Cooper's ligament, which can be the medial landmark of the medial dissection. So I'm just trying to reduce the bladder further here, and this is the Cooper's ligament and the pubic arch. So once the Cooper's ligament is exposed, you can see, and now little bit of further dissection bringing down the preperitoneal fat. Little bit of fat plug was there in the femoral canal, so I finally completely reduced it. So on further dissection, external iliac artery vein will come, but ultimately you need to assess whether how much dissection is required, and once we get at least 6 to 7 centimeter space all around the defect area, I think it's good enough for the proper mesh overlap. So I'm just trying to assess whether the sigmoid colon has come inside completely, as you can see. So it has come inside completely, and the dissection seems to be almost complete. Here is the defect. Around 4 to 5 centimeter defect size was there. So now after completion of the dissection, we need to close the hernial defect. So I'm taking a 10 non-observable V-lock suture. It's a PVT suture, and started closing the hernial defect starting from the lateral end and gradually go up to the medial end. While taking the bite from the defect margin, I'm taking a few bites from the roof of the hernial cavity, so that once I pull the suture, that will close the dead space and reduce the chances of seroma formation. Here again, very gently and very securely we need to take the bites, and while we come to the medial margin, there will be infraepigastric vessels. We have to be carefully take the bites from the hernial defect margin. So hernial defect should be closed nicely, and that is the one important step. So proper understanding of the anatomical aspect and laparoscopic suturing skill is required to nicely close the defect. So you can see I am just converging onto the medial most aspect of the hernial defect, where infraepigastric vessel is actually lying very close to the defect margin, but I was able to close the hernial defect, and again came back few bites to from where we have started. So now it is being completely closed. So now taken a 15 centimeter, will take some 15 centimeter infant feeding tube to take it inside and measure the area. Here it is. So it's a 15 centimeter infant feeding tube I have taken inside and measuring the area for the mesh size. Here I found that 15 by 15 centimeter mesh shaped in a circular manner will be good enough. So here it is. So it's a medium weight polypropylene mesh, medium weight flat sheet of polypropylene mesh, which is placed inside and nicely tucked beyond the peritoneal folds, so that the lower border of the mesh should lie flat and nicely tucked inside, should not folded upon once we deflate the pneumoperitoneum. So here you can see it is nicely placed, and now I have taken a 30 absorbable V-lock suture and will take few bites, few point fixation. So decided to put one stitch proximally. So that will keep the mesh secured at its place. So this is one point. And medially I decided to put one more fixation with the undersurface of the left rectus abdominis muscle. So this is a self-locking suture. So I just not given a knot, I just kept the suture taken 2 bites and kept the suture like that. So it's just to anchor the mesh till the mesh get fixed with the abdominal wall, and it will remain like that. And finally, with the same suture, I have decided to close the peritoneal fold, the peritoneal flap. So started from the lateral end, started closing the peritoneal flap. So during the process of dissection, there was no peritoneal rain that has been created. So it's a intact peritoneal float, the flap that has been raised. Had there been any peritoneal rents, that could have been also closed with the absorbable V-lock suture, because no part of the mesh should be exposed to the intra-abdominal contents. And taking 3-4 bites at a time, and then we'll pull the suture. So gradually starting from the lateral end, coming onto the medial aspect. So you can see gradually I'm coming towards the medial end, and nicely the peritoneal flap is getting approximated with the anterior abdominal wall. And so this patient did well. It took me around 1 hour 20 minutes to do this surgery, and patient was mobilized within 4 hours of surgery. This procedures are actually very painless, because there is hardly any fixation of the mesh, and patient can be mobilized within a few hours of surgery, and diet can be allowed, and patient get discharged from the hospital on the very next day. And finally, before deflating pneumoperitoneum, take out the preperitoneal gas with suction. That completes the operation.